My answer is always yes, because we all know that ARNI is a much better molecule and has got added advantage as compared to ACE inhibitors. So every patient of decompensated heart failure, whether a patient was on ACE inhibitors, ARB, or was on no RAS blockade, they all can be potential candidate for ARNI. Now, 2-3 points to be considered here. Number one, a patient has to be hemodynamically stable. What does it mean? Systolic blood pressure has to be 100 millimeter of mercury minimum and should be maintained without the need of vasopressors, inotropic agents, vasodilators. And second point, patient preferably should be off intravenous diuretics and should be on a stable dose of oral diuretics. So once a patient of ADHF has achieved this state, a blood pressure of 100 systolic millimeter of mercury without inotropes and vasodilators, and diuretic dose is stabilized, these are the patients where you can think to start ARNI. Obviously, 2-3 important points for ARNI is, number one, if patient was on ACE inhibitors, you have to be careful that at least 36 hours have passed after you stop ACE inhibitors. We need to check on eGFR and potassium also. Patient's potassium level should be less than 5.5 and eGFR has to be more than 30 ml per minute. If these conditions are satisfied, I'm pretty good at starting ARNI, because Pioneer HF trial did suggest that if you start ARNI in patients before they are discharged, there is a better chance that they will continue getting ARNI. They'll be maintained on ARNI, and then their composite endpoint at the end of 1 month in terms of morbidity and mortality is much reduced. So ARNI even in ADHF patients.